like to welcome everybody who is checking in on our recommendations from MAHEC on mechanical ventilation. Welcome. This is being put together to give people a review course of the important principles in mechanical ventilation during this period where we're seeing so many patients with acute respiratory distress syndrome. I am the medical director of the Simulation Center. My name is Paul Rogers. I'm retired and I was a professor of medicine and critical care at the University of Pittsburgh. I now teach medical students and residents and faculty at MAHEC, and we've been going over this in our classes, and I was asked to have this videotaped so that people who can't be here would have an opportunity to review it. Now let me just say that I'm presenting the way that I was taught how to take care of people who have severe ARDS. I'm going to be covering principles that were identified in the ARDS-NET trial. I'm going to be talking about most recent advances in proning. These are the way that I was taught to do it. There are other ways, and we have some references in our presentation that you can take a look at. And again, I want to go over the highlights of the management of those patients so that you'll know things to look out for and issues to bring up to other faculty who might be working with you. So what we're going to talk about in the next hour or so is what are the indications for even putting this person on mechanical ventilation. And then once we decide that they're going to go on mechanical ventilation, how are you going to go about providing the delivery of a tidal volume? Are you going to do it through giving a volume to your patient, or are you going to give it through a pressure? And we're going to describe strategies for ventilatory support, including oxygenation and ventilation. I'm going to be going back and forth between the PowerPoint that you can see and my whiteboard. So please bear with me as I move back and forth. The indications for mechanical ventilation are simply extensions of if you go to a patient and begin bag masking them, in almost every instance, you're going to be moving towards intubation. A patient who can't breathe, a patient who's not able to protect their airway, a patient who has severe hypoxemia and is not responding to maximum amounts of non-invasive oxygen, or people who have increased work of breathing. Now what I'm going to be focusing in on today is just the refractory hypoxemia. So we're going to be talking about oxygen support. And what I need you to understand is that the goal of oxygenation is not to attain a specific blood gas value. For example, a specific arterial oxygen or a specific arterial oxygen saturation. It's the physiologic delivery of oxygen that is the most important concept. Now, in order to understand what I'm referring to, we need to just look at oxygen delivery being reflected by cardiac output times hemoglobin times your saturation of oxygen plus the arterial oxygen times 0.0031. So the important member of the oxygen that you want to be looking at is not the PaO2, because it's multiplied by such a small number that it's insignificant. This is what you want to be looking at. And if this begins to drop, then what is that doing in the cardiovascular response? Since cardiac output is stroke volume times heart rate, most likely it's going to be resulting in sinus tachycardia. What you want to be doing is making your ventilator changes to get you the best oxygen saturation with the least amount of effect on this cardiac output. Now, when you are putting a person on the ventilator, if their oxygen level, their oxygen saturation is good on 20% room air, 30% or 40%, if they have a fairly normal AA gradient, then when you put them on the ventilator, you can just put them on 50% oxygen. If they have an increased AA gradient, you need to put them on 100% oxygen to begin with. So before we go further, let me just quickly review that if this is your alveolar oxygen and this is ventilation and this is perfusion, when you begin to have a decrease in your ventilation or a decrease in your perfusion, these are called ventilation perfusion mismatches. It is decreased ventilation that's going to result in hypoxemia. If you get to the point where you have absolutely no ventilation going on, the alveoli is collapsed, then when you add oxygen to your patient, if there is no ventilation that's going on, there's not going to be a response with an increase in your oxygen sat. Whereas these, which have some decrease in ventilation, the oxygen can get down and it's going to result in an increase in your O2 sat. So the point here is if you have a patient who is hypoxemic and looks to be in respiratory distress, what I would like you to do is to put them on 100% FiO2 face mask. If the saturation comes up, you know that they probably just have a VQ mismatch. If the saturation does not come up, then that's telling you that over 40% of the cardiac output is going past the area in the lung that is got pathology. Cardiac output is going through here, and more than 40% is not being oxygenated. And when that happens, your O2 sat is going to stay the same. So if I have a patient who's hypoxemic, let's say their sats are in the mid-80s, I put them on 100% FiO2, it doesn't change. That tells me I have a shunt, it's greater than 40%, and I need to start bag masking so I can open up these alveoli. I do not need to get a chest x-ray or a blood gas. That is going to help me with the etiology of the hypoxemia. I need to get the oxygen up immediately, and that means I'm going to be bag masking. So if I've put them on a FiO2 of 100%, once I get the patient intubated, I want to put the ventilator on 100%. But my goal in the next 24 hours is to get this down to 60% so that there's not any toxic reaction from the high FiO2. And the ways that we're going to talk about doing that is by adding positive end expiratory pressure. But we need to make sure that as we increase the amount of PEEP, that we are not causing any volume trauma, which is going to be reflected in high peak and plateau airway pressures, in particular the plateau airway pressure, and we're not going to decrease the cardiac output. This is a patient, let's say that you have put on 100% oxygen and the SATs did not improve, and you've intubated them, and you have this chest x-ray. The chest x-ray shows diffuse alveolar ventilation that is consistent with ARDS. We talked about the fact that in order to improve the person's oxygen sat, we're going to put them on an FiO2 and positive end expiratory pressure of 5. That's where we're going to start. Once you've intubated a person, the next thing you have to address is maintaining their PCO2. And I have found this relationship to be helpful, that the PCO2 is going to be inversely proportional to your respiratory rate and your tidal volume. The other components of the equation are production of CO2 in dead space, but what I want us to focus in on is the respiratory rate and the tidal volume. And that if you have a minute ventilation of 8 liters a minute on your ventilator, you're going to have a PCO2 of 40. So what that means is if you intubate a patient and you want their PCO2 to be 40, you need to set them with a respiratory rate and a tidal volume that is going to give them 8 liters or 8,000 mLs. Now the recommendation for the initial tidal volume is 8 cc's or 8 mLs per kilogram. And if we have a patient who is, let's say, 80 kilograms, that's going to be 640 cc tidal volume. Now, rounded out, we're going to say it's 650 cc tidal volume. So if I want to give a 650 cc tidal volume, then what I will do is divide that into 8 liters, and I'm going to come up with a respiratory rate somewhere around 12. So that's my initial ventilatory setting. Now after that person has been intubated, you can then get a blood gas and adjust your respiratory rate accordingly. Now, some of your patients may have an underlying metabolic acidosis because they are hypotensive and they're being poorly perfused and they're creating a lactic acidosis. And I just want to point out that I'm just going to make up this blood gas. Let's say that they are acidotic and they have a low bicarbonate, their O2 is low, and they're blowing off CO2. If you set this person with a minute ventilation of 8 liters, their PCO2 is going to be around 40, which means that they're going to become more acidemic. And so when you are sedating and paralyzing a patient who has an underlying respiratory metabolic acidosis, it's important to look at the blood gas, find out where the PCO2 should be, and then using this chart, which just says 8 liters gives me around 40, 20 liters gives me around 20, and then 30, a PCO2 of 30 is somewhere around 12. So it gives you an idea of where to aim your respiratory rate. Now, there are several ways to provide ventilatory support. One of them is complete support. In other words, we're going to do all of the work of breathing for our patients, people who are sedated and paralyzed. The Partial support is when we're trying to wean people or we're trying to give them some muscle utilization so that they aren't completely deconditioning their muscles. I'm not going to be talking about those modes. I'm going to be talking about the initial setting for complete support of people who have ARDS. And we're going to talk about two types of ventilatory support. One of them is I'm going to give the patient a volume, and the other one is I'm going to give the patient a pressure. So here is my patient, and he has an ET tube in that's hooked up to this ventilator. Now, we've already said that we're going to set the FiO2 to 100%, and that we're going to put the PEEP at 5, and since he weighs 80 kilos, we're going to put him at a tidal volume of 650 and a rate of 12. Now, the question is, how does the ventilator give a tidal volume of 650 cc's to this patient? And here are the patient's lungs. And this is going to be the ET tube with a balloon in it, so that when the volume is put into the lungs, the air does not leak out. And when this volume goes into these lungs, there is a pressure that's generated. And compliance is the change in volume over the change in pressure. So if the lungs are perfectly compliant, when we give a tidal volume, it's going to give a slight increase in pressure. But if the lungs are very stiff, that same volume is going to create a much higher pressure. Let's see. Now these things that we are setting right here, that I have set, that you're going to set, are your independent variables. So this is set. The tidal volume is 650. Now when this volume goes into the lungs, it's going to create a pressure. And that is the dependent variable, because it depends upon the compliance of the lungs and the chest wall. And we're going to get into why this pressure is important and how to measure it in a minute. We're going to go over volume control and assist control, and I'm going to show you how that tidal volume is created in a minute. There are two other ways that you may have heard of: intermittent mandatory ventilation and synchronized mandatory ventilation. I am not going to cover those. I will briefly discuss them, but the majority of my talk is going to be on volume control and assist control. Likewise, if we decide to do this exact same thing with our patient, and it's hooked up to a ventilator, this is a volume and this is a pressure. We are going to set our FiO2 at 100%, our PEEP at 5, but instead of setting a tidal volume, we're going to set a pressure. So let's say, for example, it's 20. Now, whereas the tidal volume, when given to these lungs, created a pressure, in this instance, we're going to give a pressure to these lungs, and that will create a tidal volume. So these are the independent variables. Pressure is set, and the tidal volume is going to be what is the result, depending upon the compliance and resistance of the lungs and the compliance of the chest wall. The two that I'm going to speak about are pressure control and well, I'm not even going to speak about pressure support, because pressure support is going to be used to wean, and my goal today is just how to help you get your patient set on the ventilator to begin with. Now, in order to know how the tidal volumes are generated, you need to understand that gas is being delivered to the patient, and something has got to trigger that breath, and something is in control of pushing that volume in, and then something terminates that breath. So, something, let's say that the flow is going into the patient, something triggers it here, and then the tidal volume is generated, and then when it reaches a certain point, then the tidal volume, or then the flow is stopping. Something stops the breath to end. All right. If I have a patient that is sedated and paralyzed, they're not breathing. They can't breathe. So if I set them on a rate of 12 and give them a tidal volume of 650, then the machine is triggering every breath. And what it's saying is I have to give 12 breaths. That's going to be a breath every 5 seconds. So in 5 seconds, I'm going to open a valve and a tidal volume is going to be generated. And then 5 seconds more and 5 seconds more. The patient is sedated, paralyzed. They can't generate their own tidal volume. Now, when that person begins to wake up, what may happen is they go 5 seconds without a breath, so the ventilator kicks in with one, but then they make an effort and their airway pressure drops, and the ventilator kicks in with either the delivery of the tidal volume in a volume ventilator or the delivery of a pressure in a pressure ventilator. So there's two triggers: timed if the patient is sedated and paralyzed, and triggered by the patient if they begin to breathe above the ventilator. Okay, so how is it that once the breath is triggered, it gets into the patient? And this is the analogy that I have found to be helpful. So this is supposed to be a tank of gas, maybe helium, at a circus. And there is a neck that comes out of the tank, and then we have a balloon that needs to be inflated. So, when the patient triggers it, or when the timer triggers it, a valve is going to open. And inside this tank, I can set the flow at 60 liters per minute. That when this opens, gas is going to come out at 60 liters per minute. Now on the ventilator, You can set the flow higher or lower, but 60 liters a minute is generally what your respiratory therapists are going to set. 60 liters a minute is 1 liter per second. So, if I want to have a tidal volume of 500 cc's, then that valve is going to be open for 0.5 seconds. Let's state it this way. Tidal volume, which is, I want it to be 500, is equal to the flow times inspiratory time. In this instance, tidal volume and flow, 60 liters per minute, are going to be the independent variables. I am setting them. This inspiratory time is going to depend upon whether I turn the tidal volume up or down or the flow up or down. Okay, so let's say that I've decided I want a tidal volume of 500. I've got my flow at 60 liters per minute. This opens up and my balloon inflates. At the end, let's just do this. Here is the valve opens, and this is going to be flow. So flow comes up, and during that period of flow, I'm going to create a pressure, because there is a relationship between I'm giving a tidal volume, which is what happens here. This is my tidal volume, and this is my pressure. As the flow go in, I create a volume. As the volume goes up, I create a pressure. Once the volume of 500 is reached, the valve closes. And then the patient starts to exhale. Now, what I want everybody to think about is, if I could measure the pressure inside this balloon, what is the pressure? What are the things that are responsible for the generation of pressure during inspiration? And there are 4 things. And if we start down here, one of the things that's going to be responsible for pressure is the flow. So for example, if you're blowing through a straw, you're going to have a different pressure if you blow gently, or if you really blow, then the pressure is going to go up. The next thing is the resistance in the neck of this gas delivery system. The third thing is going to be how stiff this balloon is, or the compliance. And the fourth thing is going to be the volume. Now, this is one of the most important parts of what we're going to talk about in setting the patient who has ARDS on the ventilator. These pressures are very important, because normally when a person takes a deep breath and is given a breath on the ventilator, they will develop a peak airway pressure. And since this is occurring during the process of the lungs being inflated, and it depends upon flow and resistance as well as compliance and volume, this is called static pressure. So this airway pressure depends upon all of these. Now, we have the ability on the ventilator this is pressure, And this is going to be my flow. Flow goes in and it does like this. And then it exhales. But we actually have the ability on the ventilator to put a pause here. It would be like if I closed this and now measured the pressure. If this is closed, then we don't have the effect anymore of flow or resistance. And so that pressure is going to fall. And that pressure that is measured during that period of no flow is called, I got this backwards, I'm sorry. This is dynamic and this is static. Because dynamic is when it's going in, static is when it's at complete standstill. And so what we did is we took away the flow and resistance, and now this is only determined by your compliance and your volume. A normal peak airway pressure is around 25, a normal plateau is around 15. So let's say that you put your person on the ventilator with your tidal volume of 650, and respiratory therapy came and said to you, my peak airway pressure is 40. So I want you to think for a minute the 4 things that are responsible for that elevation in peak airway pressure. They are flow, resistance, compliance, and volume. Now, I'm going to now put a pause. Because there's no flow or resistance, the pressure is going to fall. And that is going to be my static. Or plateau pressure. And it's 15. And so, by recognizing the difference between this one and this one, you can say, well, the static pressures are the same, so it's not a change in compliance or volume. It has to be in flow or resistance. So you go look at the ventilator, the flow is still set at 60 liters per minute. It has to be an increase in resistance. So what you're going to do is look and see, is the endotracheal tube kinked? Is the patient biting on the ET tube? Is there a mucus plug? Does this person have a increase in airway resistance with bronchospasm? Now, contrast that to, we started out with 25 and 15, and now the peak is 40 and the plateau is 35. Well, the plateau pressure has increased, which means that there's either been a change in compliance or a change in volume. And I didn't change the volume, so it has to be that my compliance is getting worse. And the things that can cause that are pneumothorax or ARDS, decreasing lung compliance. What we're going to learn in a little bit is that that number right there is what was identified in the ARDSNet trial as being a clue to the fact that we may actually be harming a person's lungs by having too high of those airway pressures. So, when we have the person on the volume, we are seeing a change in pressure if the compliance decreases. And this is for your review, which just shows that if the peak and plateau are both normal, the lung physiology is normal. If you have a high peak airway pressure and a normal plateau, this is secondary to flow or to airway resistance. If they're both elevated, it's a decrease in compliance. Now what I'm showing you on this slide is what that waveform, when I'm drawing the peak and plateau airway pressure here with the flows, looks like on the ventilator. So in this instance, you are in the volume mode, and this person has a tidal volume of 500 with a rate of 15. And he is or she is on 35% with 5 of PEEP. Now, that means with a rate of 15, we're going to be breathing every 4 seconds. So right here, the valve opens, the flow goes in, the airway pressure goes up, and then the person is exhaling. So this is their peak airway pressure, and it is reflected over here as a peak airway pressure of 19. Now what's going to happen is there is a button under the controls which allows you to put a pause on your airflow, and you can see that when there is no flow, that there's a drop in the peak airway pressure, and that's going to be the plateau. And that person's plateau airway pressure is right around 16. All right, here's our patient with ARDS. We've put them on 100%. There's no improvement in their oxygen. We know that that's shunt. We start bag masking them. We sedate and paralyze them. We put them on 100% and 5 of PEEP. And we're going to come up with a respiratory rate of 12 and a tidal volume of 600. Now when we do the chest x-ray, it shows this. But when we do a chest CT, there is worse consolidation in the dorsal part of the chest x-ray. And you can see that there's actually normal lung anteriorly. So where is that tidal volume of 600 going? Well, it's going to be going to these more compliant lung areas. That is not going to help with the oxygenation, which is why we are going to want to add positive end expiratory pressure to try to open up these consolidated areas. This is the person's airway pressure. And we'll say that this is at 0. Now when we add 5 PEEP, that's 0 and that's 5. This is what's happening. This is the peak. This is the mean airway pressure, which is the pressure that's distributed over time. When we increase the airway pressure, the mean airway pressure, and now we've done it because we've added 5 of PEEP, the mean airway pressure is what's responsible for opening up these consolidated areas. And so over a period of 24 hours, your responsibility is going to be to come down on the FiO2 and to go up on the positive end expiratory pressure. But, well, let me go back to this slide. This is what's happening. Here is the consolidated area. By adding PEEP, you're popping open the alveoli. But then when this person exhales, by adding positive pressure, you pop open this. But then when they exhale, it collapses. So how do we keep it open? We add expiratory pressure. That's the reason for adding positive end expiratory pressure. But just look at this. here was my peak airway pressure, and now I added PEEP. It went up. And if I have to keep on adding PEEP, it's going to keep on going up. So I know, according to the ARDSNet trial, that I don't want a plateau that's greater than 30. So as I'm adding my positive end expiratory pressure, I want to always go back to the ventilator and look, what is that doing to my peak and plateau? And if my peak or plateau is starting to go up, then I only have one choice to make. If I'm giving a tidal volume and I've got, let's say I've taken my PEEP from 5 to 10, and now my plateau is approaching 30, I need to get that FiO2 down. So I can't decrease the PEEP. What you are going to need to do is reduce your tidal volume. And towards the end of this, I have a table that the ARDSNet recommends. And what it states is that we should be aiming for about 6 cc's per kilo in patients who have ARDS. So we're going to be lowering our tidal volumes. Now, here is a patient who, let me just show you what that is a picture of. This is change in pressure, and this is change in volume. When these are our lungs, when your intrathoracic pressure is getting more negative, then the patient's lungs start to inflate, and that's the normal pressure volume curve, which is right in here. And at this lower end, when it's all collapsed, you can see all of the consolidation. And as they increase the pressure in the lung, both through the tidal volume and through the PEEP, you can see how areas of the lung become more expanded. And then when the patient exhales, it moves towards more closure. What we have to be careful about is if the plateau air pressure gets above 30, you actually get to the point where you are increasing pressure, but mostly over-distending alveoli, and that's reflected on this loop. We don't want to get to the point where we're over-distending the alveolar, because that is stretching and injuring the alveoli, and that's why in the ARDSNet trial, once you get to a plateau of 30, you want to cut back the tidal volume because you don't want to cause worsening lung damage. All right, so that is the ventilatory strategy using volume ventilation. Now I'm going to talk about just a second the strategy for the pressure ventilation. Let's recap. In volume ventilation, we're going to set a timer, which is either if the patient is sedated and paralyzed, the trigger is the timer. If the patient wakes up, they can make their own inspiratory effort, which will then trigger the ventilator to give that tidal volume. And what controls this is going to be, we set a tidal volume, we set a flow, and the ventilator opens the valve and there's an inspiratory time. And when that goes in, it's going to create your airway pressures. Once the tidal volume of 650 has been generated, the valve closes and the tidal volume is finished, and then the rest of the cycle is exhalation. Now, if we are deciding that instead of giving a volume, that we are going to tell the ventilator we want to put in gas flow until a pressure of, let's say, 22 is reached. That pressure of 22 is going to create a volume depending upon the compliance of the lung. So if you have normal compliance, 22 may give you a tidal volume of 700 cc's. If it's a very stiff lung, then it may give you a much smaller tidal volume. So you need to set a pressure, and you are going to set a rate, let's say 12, and in this instance, the respiratory therapist is going to set an inspiratory time. What is going to happen is that there's going to be an inspiratory time, the flow is going to go in, and during that period, pressure is going to be generated up to 22, and then depending upon the compliance, you're going to get a tidal volume. Then the person is going to exhale. So in a pressure support, a pressure controlled or pressure assist ventilation, what controls the breath is the pressure, controls the delivery of the breath. The highest flow is provided at the beginning of the inspiratory effort. Then it goes through the airways early in the cycle that allows more time for the pressure to equilibrate. And then the flow is going to decelerate as a function of this rising pressure. And then what's going to terminate the breath is, in this situation, is time. Once the 1 second is over with, we're done. Now let's just quickly look at these so that you can take a look at them. I'm going to look at volume control and volume assist, and pressure control and pressure assist. These are my two volume ventilators, these are my pressure ventilators. This is volume over on this axis, this is flow, and this is airway pressure. So in the volume control, I'm going to set the volume, and I'm going to say it's 650 cc's. And I'm going to set the flow, and it's going to be 60 liters per minute. So if the patient is not breathing, every, let's say, 5 seconds, the valve opens, the flow goes in, and then the reason there are these dotted lines is because these two, flow and volume, I set. They are indeterminate. This one is the one that depends upon the independent variables. And it depends upon whether or not compliance is reduced. So if I have a very stiff lung, it's going to have a higher airway pressure. The only difference between volume control and volume assist, these are the same, this is the same, is that this patient takes a breath and gets their tidal volume, and they get the whole volume. Now in pressure control, again, what I set here is pressure, and I set the inspiratory time. When the trigger says the valve is going to open, the flow goes in, and then it creates various tidal volumes depending upon how stiff the lung is. And the only difference between pressure control and pressure assist is that pressure assist, if the patient takes a breath, it will trigger it. I am not discussing pressure support today. That is a mode of weaning, and that will be later in this patient's progress, and you can get a team together that will look at weaning criteria. I'm trying to help you get the initial stages of the ventilator set. So, in controlled breathing, you'll see the person is getting a tidal volume, tidal volume, tidal volume, and in assist control, they're taking a breath and it's triggering the ventilator. This is IMV and SIMV, which I'm not discussing because I don't think they'll be used in your patient population for the management of acute lung injury secondary to the coronavirus. This is the pressure ventilation where the valve opens, the flow goes in, the pressure is generated, and that is going to create your tidal volume. Now, let's just see, hopefully, that I have explained this well enough, that let's say that you decide you want to put your patient on pressure control ventilator. You're going to set the pressure, let's say 25 centimeters, and the volume that's going to be delivered depends upon the patient's compliance. So, the nice thing about that is that if you are in the volume mode and the patient's compliance get worse, then the peak and plateau airway pressure can change and cause damage, and you would only be notified if the alarms had been set appropriately and had gone off and said you've exceeded the plateau or the peak airway pressure. In pressure control, you can't get higher than the pressure you've set. So if you have set your pressure for 28, then the airway pressure is going to be limited at 28, regardless of the change in resistance of compliance, thus preventing any damage to the alveoli. Now the problem is that if the compliance falls, then what's going to happen is the tidal volumes are going to start to fall. So you have to be aware of that. Let's just say, for example, solve this problem. You have a patient who you have set a pressure of 25, an inspiratory time of 1 second, a rate of 12, and it's delivering a tidal volume of 700. And then 4 hours later, with the exact same thing, 25 inspiratory time of 1 second, rate of 12, and now the exhaled tidal volume is 400. Something is happening. And what you need to do is go over and listen to the patient, get a chest x-ray, and rule out bronchospasm, pneumothorax, ARDS. Now, we've said that if your patient has a normal AA gradient, we're going to put them on 50% and 5 of PEEP. If they have a high FiO2 and are still hypoxemic, which means that they have an impaired alveolar arterial gradient, then you need to be putting your patient on 100% and decreasing the FiO2 over the next 24 hours. Now, the goals of the PEEP in this situation are going to be several. One is that, as I told you, you want to increase the mean airway pressure, which is going to improve oxygen delivery and open up the alveoli, and you're going to do the increase in mean airway pressure by increasing PEEP. At the same time, what you have to recognize is that if you started out with, let's say, 5, and that's your peak airway pressure, let's say 25, that every time your PEEP goes up, everything is going to go up. And therefore, every time you do this, you need to check and see what your peak and plateau are. If the plateau is greater than 30, the only thing, you can't turn the PEEP back down because you're trying to turn your FiO2 down. What you need to do is to reduce your tidal volume to 6 cc's per kilo. The other thing that you could do at this point is to then change to a pressure mode of ventilation. And you could say, okay, I need to keep my plateau under 30, so let's put this person on pressure control of 28 and see what tidal volume is generated. That way, you're not going to get a airway pressure or trauma to the lungs by having too high of a pressure. So pressure ventilation, and I want you to focus on pressure control. Now, let me see. Let me give you an example of what I mean by adjusting your PEEP with several goals. So here they are. 1, increase PEEP to get FiO2 less than 6 or at 60 in 24 hours. 2, as you add PEEP, you have to continually follow your peak and plateau. And if the plateau is greater than 30, you either decrease your tidal volume or you change to pressure control ventilation. And number 3, you make sure you didn't decrease oxygen delivery. Now, I'm going to leave that up for a second, and I'm going to give you an example. This one happened when I was in training, and people involved were focusing in on this aspect. So let's say that you have a patient whose blood gas is 738 and their PCO2 is 40 and their PO2 is 60 and their bicarb is 24 and their SAT is 92 and they are on 60% FiO2 and I'm going to just say 12.5 of PEEP. Now, what the novice learner or clinician did was look at this and said, that's not very good. Although, we know from the hemoglobin dissociation curve that once you get above 92%, that your PO2 of 60 is 92%. That's adequate. And furthermore, what you can look at in the oxygen delivery equation, which is delivery is cardiac output times hemoglobin times SAT. If that was inadequate, we could predict that maybe their heart rate goes up. But this person's heart rate was fine and they were making plenty of urine. So what happened was the person came along and said, well, I don't want to increase his FiO2 because I got it down to 60%. So I'm going to go up on the PEEP to 15. And then we got this blood gas, maybe 30 minutes later. And so everybody was very happy because look how much the PaO2 improved. Well, in about an hour or an hour and a half, he had developed a significant metabolic acidosis and decrease urine output. And if you look at this equation right here, which is oxygen delivery is cardiac output times hemoglobin times SAT plus your PaO2 times 0.0031. So I don't know what his cardiac output was, but I'm just going to tell you, let's say it was 6 liters a minute, and the hemoglobin was 14, and the SAT was 92, and the PaO2 beforehand was 60. After they made their intervention, the hemoglobin was still 14, the SAT came up to 96, which is an increase of 4%. But when they measured the cardiac output, it had fallen to 3 because the intrathoracic pressure was so high it was decreasing venous return. And so this fell by 50%. So this went up by 4%. This went from 60 to 80, but 80 times 0.0031 is still insignificant. The point was they didn't realize that by increasing the pressure they had actually decreased the cardiac output significantly. So you have to be aware of that. If you go up on the PEEP and you begin to see an acidemia or you begin to see decreased urine output, then it's important to evaluate the intrathoracic effects of PEEP on cardiac output. All right, now if we have gotten our patient onto pressure control and we're still having problems with oxygenation, this is what the patient's chest CT looks like. This is what would happen if we took them and put them on their stomach or proned them. And this is what I want you to know. For most patients with ARDS, giving a low tidal volume in the supine position rather than in the prone position is the initial strategy. And you can use either a volume ventilator or a pressure ventilator. I usually use a volume ventilator, and I only move to pressure ventilation in the event that I'm having problems keeping the plateau less than 30. In patients who have a PaO2 to FiO2 ratio of less than 150, you're going to put them on 60% and more than 5 of PEEP. That is what you should be considering in this prone position. And what they have demonstrated is that rolling a person into a prone position, there's dramatic improvement in their oxygenation. Because what proning does is it promotes opening up in a more homogeneous way the lungs of patients who have ARDS. And in fact, when they measured the shunt fraction, we've demonstrated that the shunt fraction is reduced by 30%. So simply by moving someone onto their stomach significantly improves oxygenation. There are plenty of trials that make the case that proning is not something we should do as salvage therapy, but it can actually improve survival if it's used early enough. And by early enough, this is usually within the first 36 hours. And it's amazing that despite the ease with which you can just roll a person over, you don't have to have additional technology. And the fact that that will improve the shunt by 30% and that it improves morbidity and improves survival, only 16% of people with ARDS have been treated with prone positioning. So it needs to be done early. It needs to be done with an experienced staff so they don't inadvertently dislodge the ET tube. And it should be maintained for a period of about 18 hours. If you're interested, I think that you should check out, there is this prone positioning and severe acute respiratory distress syndrome, which has been referenced and talks about how to go about doing that. Now, let me just ask you, I'm going to tell you that this person is on 100% non-rebreather face mask. And so what I want you to be thinking about is what FiO2 and initial PEEP would you put the person on? This is on 100%. So what I want you to have decided is that you're going to put them on 100% and 5 of PEEP. And what mode, so what FiO2? And then what mode? You can either put them on volume, assist control, or pressure. Now, I'm going to say this guy weighs 100 kilos. And I want you to think about what tidal volume and initial rate you're going to use. So in order to know that, we need to get his blood gas. And his blood gas was 738, 40, 60, and 24. So you need to be thinking about what respiratory rate and tidal volume do you want to give a 100 kilo man to keep the PCO2 of 40. So just think about that for a second. All right, so if I want them to have a PCO2 of 40, I need to have 8 liters minute ventilation. And if they weigh 100 kilos and I'm using 8 cc's per kilo, then my tidal volume here would be 800, which means I would give a rate of 10. Now, I need to know what the consequences of this tidal volume are. Since I'm giving a volume, I need to know what the pressures are. So if I had, let's say, a peak airway pressure of 40, and I measured the plateau, and it was 35, what would I do? And the answer is, I need to start coming down on my tidal volume. In 24 hours, I need to be at 60% FiO2. And the way that I'm going to get there is to increase my PEEP. And that if I'm going to do that, I have got to be following peak and plateau pressures. And I have to be aware of whether I am interfering with a decrease in oxygen delivery. If I decide that I'm going to put this person on pressure control, I have to set the rate. I'm not setting the tidal volume. I'm going to give a pressure and measure the tidal volume. And the pressure that I'm going to set is going to be less than that plateau airway pressure of 30. I think that that is all that I want to say. This is our man with that x-ray of the person who we've just discussed. And this goes through our suggestions for establishing ventilator settings. Select your mode, select the FiO2, increase your PEEP and decrease your FiO2 to make sure that you get an FiO2 of 60% and a plateau of less than 30. This is the initial tidal volume of 8 mLs. Decrease it by 1 ml per kilo every 2 hours until you get to 6 mLs per kilo. Adjust your tidal volume and respiratory rate to keep your plateau airway pressure less than 30. And if you are having difficulty oxygenating within that first 36 hours, consider early proning. And I have included some criteria for initial ventilator setup and management that came from the ARDSNet trial, from the NIH, NHLBI, and the ARDS Clinical Network. And we appreciate your time listening to this. I hope that it has helped clarify some information for you. And we are all very grateful for the work that everybody is doing in taking care of patients at this time. Thank you for your time.